Today, I am pleased to introduce our guest. I'm going to introduce Dr. Anita Misra-Herbet. She is an associate professor of medicine at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. She's staffed in the Department of Internal Medicine and Department of Qualitative Health Sciences, the Center Director, Healthcare Delivery and Implementation Science Center, and the Cleveland Clinic Site Lead for the CTSC. Her research involves studying initiatives to improve population health through primary care redesign efforts using mixed methods. Dr. Misra-Herbet, thank you so much for joining us today. And I will also allow you to introduce your colleagues that will be joining alongside you today. So welcome and thank you. And we look forward to the conversation.
Thank you so much, Laura. Well, I am thrilled to be able to speak to you today. We are going to be focusing specifically on implementation in clinical settings. I'm going to give you a little bit of background on implementation science and then really have my colleagues, who I'll introduce in a second, talk to you a lot about their work that they've recently been doing. We just delivered a half-day symposium on implementation science through the CTSC a couple months ago, and that was focused on a couple key topic areas, one of which we're going to really focus on more today. So this is more practical, what we're working on, and hopefully there'll be lots of questions. So if trying to advance slides here. Okay, here we are. So I'm going to introduce my colleagues who are also going to be presenting here today. First, Dr. Valerie Chepp. Valerie is our qualitative methodologist in our Healthcare Delivery and Implementation Science Center at Cleveland Clinic and is part of our CTSC core dissemination implementation team. Dr. Stephen Massiano, who is our quantitative methodologist in our Healthcare Delivery and Implementation Science Center, and also part of our CTSC D&I core team, and Dr. Belinda Uday, who is the Director of Health Economics in the Department of Quantitative Health Sciences at Cleveland Clinic, and again, part of our D&I core team. So hopefully you get to know my colleagues and know that we are going to be resources for you and with any questions that you may have related to dissemination and implementation and thinking about how to incorporate this into your work. So just a quick overview, where does implementation fit in into your clinical research or basic research world? We normally are used to thinking about this as a linear spectrum from basic research to preclinical, clinical, and then clinical implementation, moving on to improving the health of our communities and public health. With, of course, the patient in the center there as the goal of all of our activities related to research and health. We really know that now, instead of being more of a linear spectrum, this basic research can actually inform implementation and vice versa. We should be thinking about clinical implementation really at any stage of our research, thinking about how we can design our studies for future implementation to improve the health of our populations. So I always put this up when I give introductory talks about implementation science. How long may it take for research findings to influence practice? There is this number of 17 years that is always floating out there. And this comes from this study in the year 2000 from Ballas and Boren. And this is just a figure that kind of shows the different areas where there may be lags in getting the results of original research into clinical practice. First of all, maybe you have negative results and you feel like, well, I'm not going to submit this to a journal. And then maybe you decide to submit it and the journal says, well, we don't really want to publish this because it's negative. But just a note about that in the implementation science world, any learnings that you have about implementing research findings into practice, even if they're negative, they're incredibly helpful. So that is maybe a bias that we have in our publication world. So once the study is accepted, if it's accepted, then it's published and there's some lag there. Then it gets into databases, maybe review papers and textbooks, And then finally, we'll get implemented. Now, of course, this was published in the year 2000. And since then, we've had major events such as a global pandemic. And now we have really made this, this period of publication and getting into databases and into review papers a lot more quick. However, just getting that into clinical practice, getting the knowledge into clinical practice is still a bit slower than it should be. So what is implementation research? Implementation research is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services and care. And we can probably all agree that we're all trying to improve the quality and effectiveness of health services and care. But this field was called relatively new in 2006 when this was published. This also includes the study of influences on healthcare professional and organizational behavior. I would say that a lot of health systems have now recognized the importance of studying rigorously healthcare delivery and the processes involved in bringing evidence-based practices to our routine practice environments. But still, I would say that a lot of clinical researchers or basic science researchers may not be aware of this field and the potential of partnering with implementation science experts to improve the impact downstream of their work. So another way to show this is that we normally implement something into practice and then we look at results, but then we're not really looking at that middle part. We think, well, a miracle occurs, this worked or it didn't work, or it worked in some places, didn't work in others, but we haven't really captured the appropriate data to understand why things work or don't work and how we can improve our clinical implementation. So a little bit about our center. So our Healthcare Delivery and Implementation Science Center, which we really see as the hub of the D&I activities contributing to the CTSC. This was established at the Cleveland Clinic in 2019, and I came on as director in 2020. We are really focused on capturing what is happening with this implementation process of bringing research evidence into routine healthcare delivery, specifically capturing any adaptations that are made and why they are made, so that when we take our results of our implementation outcomes, we try to improve how we're further implementing, or the next time we try to implement this particular practice into routine care, if we can do it better. And the important thing about implementation science, the buzzword is context, and context at multiple levels of evaluation. So evaluating context at the individual patient level, at the provider level, at the practice site level, the health system level, community level, regional level. So it's really important to think about which levels of evaluation are most contributing to the success or potential failure of your implementation efforts. So another really important concept is our alignment of implementation science researchers with operational leaders to improve the quality of healthcare delivery. And this was something that we spoke about during our recent symposium, and my colleagues will be sharing additional thoughts, more specific thoughts about this. This I just really wanted to cover because a lot of times you're not really sure how your project relates to implementation, and is it ready to be implemented and to do an implementation study. So I think this is a great reference. Dr. Lane Fall and colleagues published this in 2019, kind of as a subway map, or is your project ready for implementation research? So just to review this, first you kind of have to identify your practice of interest, or the evidence-based thing that you're trying to implement into routine clinical practice. Has this practice of interest shown efficacy? And if it hasn't yet, then you're not ready for an implementation study. You're ready for efficacy research. And then maybe during that efficacy research, you are thinking about downstream implementation and thinking about designing your study so that you can capture some data about future implementation. If the practice has shown efficacy, then you have to ask if it's shown effectiveness. Has it shown effectiveness in real world populations? And if not, then you do need to do effectiveness research. And if it has shown effectiveness already, then you're ready to actually do a full implementation study, which would include something like mixed method studies to understand context, designing implementation strategies, and then testing those strategies. So an implementation trial typically would be testing different strategies to implement that evidence-based practice into routine care. If, for example, your practice has shown effectiveness in a particular population, but now you want to test it in a different population, perhaps you still need to do effectiveness research. And there is an opportunity to do something called hybrid effectiveness implementation trials. And there's a lot of literature on that. And essentially, it's where you're maybe doing a clinical trial primarily focused on effectiveness, but then you're also capturing implementation outcomes, things like acceptability, feasibility, and adoption of that particular practice, even within the context of your clinical trial. And getting that information while you're just running a clinical trial can really help you with future implementation to larger populations if you do show effectiveness of your practice. So now I want to just more specifically talk to you about something that our center has been involved with. In 2022, the Patient-Centered Outcomes Research Institute, PCORI, offered an opportunity for health systems and health plans to apply to be part of a new program called the HSII, the Health Systems Implementation Initiative. And in 2023, we found out that we were one of 42 health systems across the country who were accepted into this program. And also one of our CTSC institutions, University Hospitals, is also participating. So that's pretty exciting to have two health systems within the CTSC participating in this program. So essentially, this is a 7-year master funding agreement with PCORI to be able to be eligible, this group of 42 health systems, to apply for funding to support implementation. Now, essentially, PCORI kind of had this thought that, well, they funded so much research that has really shown a lot of effectiveness, but those findings are still not being implemented into routine practice. And so let's put aside some funding just to focus on implementation. So this is really an exciting program and so aligned with the way our center was thinking. And I think just nationally, there's a lot of conversation about aligning operations and implementation research. So the interesting thing about this program is that there was a requirement to have senior operational leader buy-in to apply for this. And it was because they're going to set aside all these funds and they want to make sure that actually change will happen within health systems. So this has been a great experience for us to be involved with this. And so just a little bit more about that, we received our first funds in July of 2023, and we're just finishing up now. And it was really a capacity building project. And all the health systems had an opportunity to apply for these funds. So basically just preparing your health system to be ready to implement future opportunities where PCORI was going to offer specific topics that you could choose from to apply for implementation projects. And again, back to that same picture that's really similar, our participation was really grounded upon this close alignment of operations and evaluation. So bringing implementation science theories and models from implementation research, aligning with operations, understanding processes, and thinking about rigorous evaluation so that we could understand those processes better. So PCORI actually offered us 7 areas of focus. We chose these 4. We started with basically just creating an internal governance and infrastructure that was supported by personnel really dedicated to help us convene the necessary resources for both the operations piece and the evaluation piece of future implementation initiatives. So we focused on developing and enhancing our teams and processes for responding to these proposals. So a lot of teams talking to each other that in the past had not been regularly talking to each other. We identified and optimized some of our implementation strategies and plans for strategies and approaches as these implementation project opportunities came about. Enhancing our EHR and some of our other technology systems to facilitate implementation and evaluation. Specifically, how are we going to capture specific implementation outcomes like adoption at the provider level or at the patient level, at the practice level, to be able to really understand our implementation outcomes. And then to enhance our data infrastructure to support this evaluation and specifically coming up with some data definitions, which you'll hear about later in terms of how to capture implementation outcomes. And we now have we applied and received funding to embark on our first large implementation project where we're planning on implementing shared medical appointments to treat obesity all across our 57 Northeast Ohio primary care practices at Cleveland Clinic. And this just started this month and will be going through July of 2028. And just the final slide just about this project. So we received $1.5 million in funding, and our target population are primary care patients age 20 to 75, BMI greater than equal to 30. And we have about 141,000 patients who could be eligible. And we estimate that those who will fully complete our program are going to be anywhere from 2,400 to 3,000 patients over our time frame. We are utilizing a group visit model from the evidence that was generated from a prior PCORI-funded study by Beppert et al. And we are expanding basically our current health system obesity management resources to be able to implement this and building on our model of shared medical appointments led by multidisciplinary teams. So this is exciting. It's a lot of what we've talked about in theory for a long time, but this program has allowed us to put this into practice. And again, I'm now going to turn it over to my colleagues to tell you a little bit more about the work we're doing. And I believe Dr. Chep will now be.
Yes, and I will. Thank you so much, Anita. I will share my screen. Share. All right. Yes, so thanks so much, Anita. When we talk about bringing implementation science to operational teams, what we really, let me make sure I can advance. What we really are talking about is bringing implementation frameworks to that alignment and implementation outcomes. Implementation frameworks are they help us evaluate what it is we are implementing, right? They guide us, they serve as a sort of roadmap for how we're going to approach or piece together an evaluation study. And so that kind of gives us a structure so we can rigorously evaluate. And then implementation outcomes are particular outcomes that we pay attention to in implementation science that help us determine or understand the success of an implementation effort, right? So what can we hold up as something that was achieved or not achieved at the end of a study? And one common implementation framework that will appear later in our presentation is the re-aim framework. So we just want to give this as an example of a commonly used framework. This is actually the framework we're using in our PCORI project. And the re-aim framework has these 5 dimensions. Re-aim is an acronym which stands for Reach, Efficacy, Adoption, Implementation, and Maintenance. And these are things that help evaluators, implementation scientists pay attention to when they are evaluating an implementation effort. So the reach is the proportion of the target population that participated in the intervention, right? How many people are we reaching with this innovation? The efficacy is the success rate of the intervention. So this is, how well did the intervention work for those who participated? This would be looking at, more clinical outcomes. How many settings or practices adopted the intervention? If only one practice adopted it out of, 57, that would help us understand how successful our efforts were. Implementation is the extent to which the intervention is sort of implemented as intended originally. And then maintenance speaks to sort of this, how well it is sustained over time. In addition to frameworks, what we bring to operational partnerships are implementation outcomes. And so this is a taxonomy of outcomes. I don't expect you to be able to kind of read through this whole thing, but I just want to draw your attention to the first column of these particular things that help us determine the success of an intervention, of an implementation effort. So acceptability, adoption, appropriateness, feasibility, fidelity speaks to that was it delivered as intended, an intervention. We pay attention to things like cost. That certainly helps us understand when we're trying to evaluate how something was implemented. Penetration speaks to how much has it penetrated throughout an organization or setting. And then again, sustainability is something that we pay attention to as well. So, maybe we don't see it as such a great success as if it was implemented, but then as soon as the evaluation period ended, it kind of dropped off by the wayside and didn't kind of have any sort of sustainment or maintenance over time. And then you can see that in this third column, this is the sort of theoretical basis that informs the identification of these particular outcomes in this taxonomy. And you can see looking down the column that re-aim does inform this taxonomy, but it's not the only framework that informs it. So there are many implementation frameworks, theories, models out there that people can use and that serve as a foundation for this taxonomy. I don't want to go into much detail about this, but I do want to just mention that re-aim, which was originally introduced in 1999, has since been extended to consider the role of changing contexts, right? The environments, as Anita said, this is sort of a buzzword in implementation science. It's context, but it's a buzzword because it's really important and it really matters. The environment in which we are implementing really matters, and that environment is always changing. And so this extension of re-aim takes into consideration that dynamic context. It also takes into consideration issues of health equity and cost as factors that play a really important role in the sustainability of an implementation effort. And then this extension was introduced in 2020, so just a few years ago. And this is actually what we're using in our PCORI project. We're actually using the extended re-aim in our PCORI project. So that's just a very quick overview of the sorts of implementation knowledge or information that we bring in our partnerships with clinical operational teams. And we know that operational teams are often already thinking about these issues and concepts, right? Of course, teams are thinking about how feasible something is or how much something costs. This isn't unique to implementation science that we're introducing this into the equation, but maybe we're using all different language, right? Or maybe operational teams don't conceptualize it as part of an evaluation framework, or they're not using the same methods that we use to rigorously evaluate. But implementation science is kind of notorious for being jargony or maybe overly technical, inaccessible. And so that's really a problem because it can hinder collaboration and partnerships. And we know that those partnerships are necessary for successful evaluation. And so at the HDISC, the Healthcare Delivery and Implementation Science Center, we've really sought to bridge that gap. And one way we've sought to do that is by developing some educational resources to convey that sort of implementation knowledge and ideas to non-implementation teams with whom we're collaborating. So non-analysts, different operational teams, and how can we convey it in kind of accessible, user-friendly ways. And so we've built some resources as part of our PCORI capacity building grant, and we just wanted to share a couple of examples of the resources that we've built with you. So the first is an infographic. On the left hand of the screen, I've put the full infographic, but I know you can't read the small text. I'm not going to read through it, but just to give you an idea that this is a resource that we can give perhaps a clinical operational team when we start planning for implementation. What does that mean to plan for implementation? In that second panel, you can see that we introduce kind of these ideas about frameworks, what those are. are, what are the outcomes that we pay attention to, what are implementation outcomes, and that we measure those outcomes using different methods. And then at the bottom of this infographic, we share that RE-AIM framework, and this is specifically that extended RE-AIM framework. And you can see throughout the infographic, we have citations. So this is really grounded in the implementation science scholarship and literature, but we don't lead with that. We don't let it kind of cloud what we're trying to say, because we want to make this very visually digestible, understandable, accessible to busy clinical operational teams. We also created a second infographic that focuses more specifically on implementation outcomes. It goes into more detail, giving definitions of what these different outcomes are, but really concise. I mean, we worked really hard to like distill these definitions in very concise ways. And then we provide a table of some of the sorts of methods that can be used to capture these different outcomes. And again, we ground this in the literature, and this is citing that Proctor table that you just saw a couple slides ago, which is that taxonomy of outcomes. And then the third resource we wanted to share with you is this data definition sheet that Anita mentioned earlier, and Dr. Maciano, who might go into it in a little bit more detail next, but he really spearheaded this effort. This is a one-page resource that we can share with different operation teams across the enterprise in our efforts to pull data from different teams, right? So this is, but it's again all grounded in implementation frameworks, our RE-AIM framework, and outcomes. So you can see going down that first column, those first outcomes line with the RE-AIM framework, but then we include the other outcomes at the bottom. We also want to measure those. And this is something that we can give to maybe a team in human resources or finance to help us and to work with us to get the data that we need to evaluate an implementation endeavor. And so really throughout these resources, we're keeping audience at top of mind. How can we create things that are user-friendly and easy to use that can really help with alignment in the partnerships that we're trying to build? And so in the remainder of our talk, myself and my colleagues are going to give you some examples of how we've aligned research and clinical operations in our work. And the first example is one that I'm going to share. This is a partnership that emerged precisely from this recognition that we're telling you about, is that, you know, implementation evaluation, especially rigorous implementation evaluation, really requires this strong alignment with clinical operational teams. And so we created a year-long formalized research clinical operational partnership program to really build capacity for implementation evaluation. On this project, we worked with a primary care team. We delivered the inaugural program in 2023, in that we focused on a referral process, implementing a referral process for patients who had prediabetes to a diabetes prevention program. And we just published on that partnership model earlier this year. And so in that partnership, we had our two teams. We started to meet to plan for implementation, really kind of living out those things that were in that first infographic, planning for implementation. We were putting that into practice. Our team, the HDISC, we created educational content, which included live 1-hour virtual meetings. We had these 8 didactic sessions teaching and educating about implementation science components. And those didactic sessions included discussion. And then we had 4 sessions devoted to project planning and debriefing. We recorded those so they could be reviewed asynchronously. And then our final debriefing session was 1 hour, and there we collectively evaluated the collaboration. Both teams came together, we evaluated the collaboration and the partnership's ability to build capacity. And then we ended up actually kind of reflectively analyzing reviewing that transcript and identified some themes. And so what we discovered was that our partnership really did create an effective model for this collaboration, and we built capacity for evaluation. Specifically, we collaboratively chose a project. We equally leveraged our respective expertise. We strategically aligned resources, priorities, and rigorous evaluation, recognizing, our two teams don't have the same priorities necessarily, right? We don't necessarily have the same resources, but what can we develop in which we all mutually benefit from something? And so that was achieved. And we also discovered that our didactic education that we delivered really directly informed the operational team's work. And so I just wanted to share a very quick example of how the operational team actually used that extended re-aim framework. They used that framework to plan, design, and evaluate their referral process. And so this figure on the right-hand side was created by the operational team, and we actually put it in an academic poster we presented at a national conference a couple years ago in 2023, or I guess a year ago. So in conclusion, while the clinical operational team certainly did learn from us, the learning was mutual. We also learned from the clinical operational team. We learned about their work environment and kind of contextual factors that inform things like feasibility or acceptability. And that is really valuable knowledge for us as a research team, because it doesn't do much good to design an evaluation study or an implementation endeavor and then realize that it's completely not feasible, right? Or it's not going to be acceptable. It doesn't fit into the real world context in which people are delivering this care. So that is where I will stop, and I will turn it over to my colleague, Dr. Maciano, to share another example with you.
Thank you so much, Dr. Chip. Yep. I hope you can see my screen.
Yes, it's just not in presentation view.
All right. So let me just go to, yep, should be in presentation.
Yes.
Presentation.
Yep.
Okay. All right. Thank you. As Dr. Chip has mentioned, there are several implementation outcomes that you can look at. So I'll be presenting an example that will kind of touch on one of the implementation outcomes that we looked at. Of course, it is recommended that you should look at as many implementation outcomes as are necessary for your study, but sometimes that may not be possible. So for the example that I'm going to give, we looked at only one implementation outcome, and that's adoption. So this example is for a study that was titled Plan of Care Visits Implementation During Hospitalization and Association with 30-day readmissions in a large integrated healthcare system. So this study has been, the article has been published in the Medical Care Journal. It is currently available online. I think next year or around January, hard copies will be available. So this study, as mentioned, was implemented within the Cleveland Clinic healthcare system as starting in early it should be late 2019. That's when the plan of care visits were implemented. So what are plan of care visits? So briefly, this is a process in which the clinical care nurse, the provider, and the patient meet as equal partners. So I'm just highlighting the word equal partners there for emphasis. So they meet to actively discuss the daily plan of care during the hospitalization. So part of the discussion may include test results, how do they look like, the medication changes that need to be made. So the intervention or the initiative was not entirely new, as maybe some of these things were happening already, but some of the deliberate actions that we are taken to ensure that this was happening in a way that was very systematic, but also the active involvement of the patient as well as their guardians, and making sure that everyone appreciated that they were bringing something to the table is what perhaps qualified this as something that was new. So, like I said, this was implemented in late 2019. So the period that we are looking in terms of evaluation is 2020 to 2022. So we could have looked at a much longer period, but when we were looking at IRB and other things, the period of interest was 2020 to 2022. So, like I mentioned, the whole objective was to assess adoption of the plan of care visits as an implementation outcome, but also there were other outcomes of interest, including assessing 30-day readmissions. But for the presentation today, we are not going to go into that. We'll just look at the adoption and how the rate of adoption varied across hospitals within the Cleveland Clinic health system in those 3 years, 2020 to 2022. So in terms of how adoption was defined, this was defined in 3 ways. It is very important to kind of mention why adoption was defined this way. Sometimes you will see that because of the study or the research question that you want to answer, you might have to look at some of these implementation outcomes in a number of ways, because maybe just looking at the implementation outcome in one way may not satisfy or may not give you the answers that you are looking for. So in this case, I mean, the adoption was defined at each hospital among all discharged patients in the same month as the proportion of hospitalized patients with at least one plan of care visit during their hospitalization. So what this outcome meant really was that it didn't matter how many plan of care visits the patient had. If you just had one, then it means that, okay, you just had one, something was happening. So that's what we were interested in. The second one was the proportion of hospital days with plan of care visits. So here the interest was in the frequency of the plan of care visits, like how frequently were the patients receiving the plan of care visits or having these discussions with the providers and the nurses. And then the last part was, were you getting the plan of care visit on the day of discharge? Because we know that the day of discharge is an important moment where you can teach patients certain things. It was also important to know whether this was happening on the day of discharge. So these 3 definitions were used to assess adoption separately. And then, as I mentioned, it means that because we're also interested in variation for each of these definitions, when assessing the variation, we had to go through each of these definitions when assessing the variation. So that's the overall, these are all the definitions that were used for adoption. And then in terms of estimating adoption, it's very important to understand that the time period for assessing the outcome of adoption needed to match with the hospitalizations themselves, because there are a lot of things that we are moving. Like if you look at the data, you'll find that maybe a patient is hospitalized in the month of February, but they are discharged in the month of March. Maybe they are hospitalized in the year 2021, they are discharged in 2022, and then you want to capture adoption for December 2021. How do you do that? So that's why it is very important to emphasize that we tried to align the reporting in terms of what the rate of adoption was in each month with what was happening in terms of the discharges in that month as well. So we estimated POCV adoption monthly for each hospital, and then we aggregated that to report monthly trends across all the sites over the 3 years. And then we modeled the rate of adoption using mixed effects logistic regressions, because we realized that, okay, there could be some clustering that's happening at the level of the provider. We have a lot of providers within the Cleveland Clinic health system. So some clustering might be happening there, but we also adjusted for patient characteristics as well as fixed effects. So hospital variation in plan of care visit adoption was estimated using variance partition coefficients. So we can talk about what that is later on if people might be interested in these methods. So in terms of the results, briefly, in panel A, for each of these panels, like for panel A on the left-hand side, you have the proportion, and then on the x-axis, you have the time period. So in terms of the proportion, we see that for the overall trends that we captured for the period 2020 to 2022, for each of those measures capturing plan of care visits adoption, there was an increase from when they were introduced to December 2022. So there was an increase, a steady increase, although we also noticed that when you just look at the whether each patient had at least one plan of care visit, if you're looking at those proportions, at least one POCV, the proportion was higher than the rest of the other measures. So that's for panel A. But then in panels B, C, and D, what we are reporting here is now the hospital variation in adopting the plan of care visits. So the hospitals that we were represented in the data are represented by each of these letters. So what the variance partition coefficient does is to capture the underlying propensity to adopt the plan of care visits that's attributable to differences between hospitals. So the red line in each of these panels represents the grand mean. So each hospital is being compared to the grand mean across these hospitals. So for example, if you have the confidence interval, crossing the red line, it means that there is no difference between the adoption in that hospital to the grand mean. So if you look at hospital H in terms of at least one plan of care visit, it means there is no difference. But we also noticed that some hospitals were not doing well. For example, hospital G compared to the grand mean. So I want to give an example of hospital K. Hospital K, for all these three measures, it was performing as well as the group average for hospital K. However, if you see hospital G, for these two measures, at least one POCV and hospital days with POCV, it was performing below the group average. But then when you introduce the third measure, which is plan of care visits on the day of discharge, it was just performing at the average, which is not below the group average when you use the other two measures. So in summary, what does that tell you? What does this tell us? This tells us that when you're looking at these implementation outcomes, for example, adoption, it is very important for you to understand what you want to do with the information. Is it just to see who is doing what, or are there particular time points during the process that you want to understand if something is happening? Or is it the frequency, the intensity of something in terms of providers doing it? So depending on what you want to understand, you may get different answers. So one hospital or one facility might perform better depending on what measure you're using. So it's very important that we understand what we want to do with these implementation outcomes when we get the results. So that's what I wanted to share with everyone in terms of this study that looked at the adoption of plan of care visits. I will now turn over to Dr. O'Day to share with us additional information. Thank you.
Thanks, Stephen. Yep. See if I can. Share my screen. Is that coming up in full view? No.
We don't see anything yet.
Is it up now?
No, unfortunately. It looks like there we can see it, and it's not in presentation view though. There you go.
Finally got it. Yeah, just my main work is in health economics, specifically decision analytic modeling. But I work with any number of teams who come and approach me, and usually they've done several clinical trials. They know that their the intervention they're looking at is effective, but there's some barrier to getting them implemented, and quite often it's the money side of it, but it's not just the financial, it's the resource availability, especially post-COVID. We have a large nursing shortage, or there's an equipment shortage. So we work together as a team to do different modeling options to see how we can get around some of those resource allocation barriers, and how we can actually get from their clinical research into making a clinical practice. So this is just an example I've given you of a liver transplant study that we're working on right now, and just acknowledging the clinical team, Dr. Worley and Dr. Schlegel, for allowing me to present this today. So just a really quick overview, is we've got huge demand for livers that were needed for transplant, but that demand still far exceeds the supply, and there can be a pretty extensive waitlist time. A large percentage of patients do die while they're on the wait list. We do have good outcomes. Once a patient does get a liver, they do live for extensive period of time. But between 50 and 20% of the organs that are procured are actually discarded for various reasons. So an important thing that we had to remember here, even though we're looking at the Cleveland Clinic specifically for this implementation program, whatever we did was going to have a great impact too on the national levels. If we were taking patients that were on the wait list, and now giving them one of these new livers that we're going to be working on, then they were going to allow additional livers to become available for those nationally. So the goal was to increase the number of livers that we needed and obviously decrease the demand and improve the outcomes for those patients who were receiving livers. But we wanted to address the barriers of implementation of this different intervention that we're going to be working on. How can we expand it and how can we continuously improve what we were doing? So the intervention is normothermic liver perfusion. You might have heard of it. It became very popular with lungs. So what this allows us to do is procure a liver and basically preserve and rehabilitate the liver for a good deal of time. It allows us to test the liver to see how good it's going to function once it's transplanted. So we're taking livers that would have otherwise been discarded. So we're going to reduce the number of those livers that are going to get thrown away. We've also shown, because we're now doing this continuous testing of the liver while it's being preserved, if you like, the complications after transplant have actually been reduced. Another big impact, which we weren't really planning on, is a lot of livers, they were very time sensitive. Patients had to be in a certain distance of the hospital to become in on time. A surgeon could finish a transplant and then have to turn around and do another transplant straight away, potentially in the middle of the night. Or even some livers were being turned away because we didn't have the staffing available. Now with this normothermic liver perfusion, we can actually schedule when we want to do the surgeries. So we can put them into daytime hours. We can hold them off until the team's had a good period to rest. And this has actually been one of the biggest benefits that the staff have mentioned, is allowing them to work a more reasonable schedule in preferably daytime hours has really helped, especially with physician burnout. The downside, of course, is that it's costly to put these livers through this perfusion, and it's also resource intensive. You need not only the machinery, you need people to watch these livers and test them around the clock. So the trials were done in the clinic, and as I said before, it was found to be effective, but it's costly. We didn't know, should we perfuse all livers? Should we only perfuse some livers? How do we get this liver perfusion program to be part of the standard clinical practice? And can we identify patients who would most benefit from it? And how can we get some information to take to the bean counters, if you like, to be able to say we want resources allocated, both space, this machinery takes up a deal of space, but we need, staffing to run the machines around the clock. We need all our consumables. So what we started with is just a basic cost effectiveness analysis, which I won't go into the details, but we just did a basic cost of effectiveness. We did it based on the Clavien-Dindo classifications of the patients. But we just looked at the costs of the perfusion, the surgery, and then the complications. And we had quite a number of patients that were at a survival at 6 months. So we used primary data to look at this initial round. So then we took that initial study and we modeling it now to 5 years. And now we're also taking it to look at the different perspectives. So we're looking at it from the hospital perspective, I should say. How is this going to affect operations, overtime, scheduling? We're looking at it from the provider perspective. There's surveys going out. There's also just general satisfaction measures being taken on burnout, not just to the surgeons, but to the OR staff who have to be on call, the surgical techs, even the ICUs. They often would get these patients in the middle of the night. They may be full. Can we also incorporate their needs into this modeling? And then also from the patient perspective, looking, if a patient, they can be called in to come in quickly. They may find once the liver is there that it's not suitable and they'll have to discard it. And that patient, they've had costs out of pocket for them to travel, to bring caregivers with them. They get all the pre-transplant testing done. So, with this normothermic perfusion, they can be further away because they've got more time to come in. And they can also not be called in until they're actually sure this liver is going to be suitable for them. And then we're continuing to extend this study now to look at, once we've looked at these perspectives, is what organs to perfuse, when to discard, because we don't want to overuse this technology because it is about another $30,000 to perfuse a liver, but we don't want to miss livers that could potentially be used. And also, is it best for certain patients with certain characteristics to be perfused over other patients? So the idea is to get the most bang for your buck, if you like, out of all the livers available and all the resources we have at the clinic. So we're using this data then to take to the operations people to help them implement it, to look at any barriers to implementation that we're coming across doing it for the clinic, but then also addressing any potential barriers that we may see implementing this at such, an institution that doesn't have as many resources as the clinic. How can we sort of address some of those barriers on the front end and try and get the most efficient and effective implementation of this technology? And as they were just continuing to work on this, but this was just a partnership that started where they came just initially for some advice and help. And we've continued, and we now have R01 grants in, we've got other funding coming in. So it's just a continuously dynamic process, I guess. So thank you.
Thank you so much. Thank you so much, Belinda, Valerie, and Stephen. So our goal was to show you kind of different opportunities to apply implementation evaluation. And the last that you just heard from Belinda, just thinking about the cost, and implementation cost is often not measured often enough. And so just for her to give you an example of just a new or change in clinical practice and the importance of being able to evaluate the cost rigorously. So implementation science is very broad. And as Valerie had alluded to, a lot of times we don't think, because we're not using the terms that are normally used in implementation science, that we're not doing implementation work. But I feel like thinking about it more broadly, thinking about what it really takes to bring evidence into practice and all the different aspects of that can fall within the purview of implementation science. And Stephen showed you an example of a new way of communicating with patients during hospitalization, and even just evaluating the outcomes of adoption of that. So we wanted to show you varied examples so that you realize that maybe a lot of what you're doing and what you may be interested in may be really implementation science. So thank you for this opportunity.
Well, thank you all so much for your time today and your talents, sharing all of your wisdom with us. We really, truly appreciate it. This session has been recorded, and we will, of course, share that with all of our attendees today and those who weren't able to attend. We will have that link sent out to you afterwards. Just a couple of quick reminders. Next month, our Science Cafe will be back in January on the 9th at 12 p.m. We'll be discussing research participant recruitment with Jerry Trubeau. We have an opportunity to share some feedback from today's session if you would like. And of course, become a member of the CTSC to stay up to date with all of our resources, our funding, and our events. So it is 1 o'clock. Thank you all so much for coming. and enjoy your holiday and happy New Year as well. We'll see you next year.